Hello and welcome to Sensei Podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei Podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello, everyone, and welcome to Sensei Podcast. It is my great pleasure to introduce our guest today, Dr. Achim Büttner from Germany, who is one of the founding fathers of CTO PCI. He took a lot of role in founding the Euro CTO Club, and he has been one of the phenomenal operators for CTO and complex PCI in Germany, Europe, and around the world. Achim, thanks so much for taking the time to speak with us today.
Thanks for inviting me, Manos. I look very much forward to your questions.
Thank you. So maybe we'll start from the beginning. So how did you go, and this was the early days, obviously, but how did you decide in the first place to do intervention and complex intervention?
Yeah, okay. In 1994, I changed from a smaller hospital to Bad Krotzingen. This was one of the big heart centers in Germany with 3,500 PCIs per year. And there I started with PCIs, and then when the senior physician of our cath lab was not in the house, I had my first experience with the first CTO patient. There were some wires on the market, new wires, the crossed wires. These were tapered tip wires, at this time from the Guidon companies, later taken over by Abbott. But this was a wire family, tapered tip coil wires, and they had 100, 200, 300, 400 with increasing stiffness. And I had these wires. And then an elderly patient came, he was post-cabbage, and he had a lot of angina. His venous graft on the circumflex was occluded. And then I said, let's try these wires. And then the wire went one way to an obtuse marginal number 2, and then it went another way, and also to the obtuse marginal number 2. This was a bypass bridge. I didn't realize it. We didn't have stents then. Then I used a few balloons, and we had a nice flow into his occluded circumflex. And then he wrote a very nice letter, and he said, now he is free of pain, and the anginas didn't meet me again since then. The anginas, bad little ladies, obviously. Very nice letter. I still have it. This was my first experience. And then, and then I started with all these antegrade techniques. At this time, I had the task to always start with the softest version of these wires, always antegrade procedures. The retrograde techniques came in 2007 or so, many, many years later. And so I always started with the softest version, and then I increased and so on. And it was nice. We had about 70, sometimes 80% success rate. Quite nice.
So even those days with equipment that we think now is primitive, right? You'd still be able to do a lot of those procedures. And how did the stents play a big role in this? Because at the beginning, right, you weren't routinely putting stents in those arteries.
No, yeah, okay. Stents were a major breakthrough. It was these bare metal stents, but a great experience. At this time, we had to mount the stents on the balloon, and we lost the stents, and had to develop some ideas how to deal with these situations. But it was a real adventure. But the real breakthrough later on came with the drug-eluting stents, especially for CTO patients.
And then, as you said, those days, there was no algorithm, there was no books. I mean, it was all early days. So how did you actually learn? Was it just trial and error to use the wires and prevent complications when you were doing this complex patients?
Yeah, okay. It was a kind of a self-experience, and we had contact with other colleagues, especially with Gerald Werner in Germany at this time, and we had small CTO workshops and exchanged our knowledge. And then with the foundation of the Euro CTO Club in 2007, then we got also contact with the colleagues from Japan, and this was another great adventure. And in 2007, 2008, we had a meeting in Hamburg in the north of Germany. The task was we should bring the patients where we failed the CTO intervention. So we collected 7, 8 patients, and the Japanese colleagues came over, and then we did these cases together. And this was my first contact with the Japanese mentality and view on this field.
And then, how did this lead? As you mentioned before, you founded the CTO Club, right? So, how was it that crossbreeding? How did you decide to do this club, and what was the goals, and how did it start?
I think it was primarily the idea of a colleague from Germany, Klaus Reifert, and maybe together with Gerald Werner. They were closely connected already at this time. And so they had the idea to collect some colleagues from Europe where they knew they are busy in that field. And so we came together and we wrote a little paper on step-by-step techniques. And so more and more material came in, also from this close collaboration of the Japanese CTI experts with the industry. So all these dedicated wires came. The Field XT was a fantastic breakthrough, in my opinion. Still the best device we have for CTO interventions. And so it developed slowly over time. And we learned from each other and visited the workshops of the others. And then it spread more and more over time.
And then, why? So, many things were coming, right? Those days, and you doing those procedures. And what did you find the hardest thing to learn and to teach? Because you train many people as well. What was the hardest thing in CTO and complex PCI for you?
Yeah, I can't directly say what is the hard thing. I think because we had some years to develop our integrate skills, and so one wire after the other came on the market, and we had enough time to get experience. But maybe the real big step was the introduction of the retrograde techniques, and especially the passage through collaterals. That is still, in my opinion, our major task where we still have to learn, where we have a constant learning process, even when we did thousands of CTO interventions. So I think this was the biggest step. Going through collaterals and then learn these special integrate retrograde wire connection techniques like reverse card, and to perform it in complex CTOs with a lot of calcium. Post-cabbage patients were always a tremendous task, and still are the most difficult patients to be treated. Yeah.
And how was it for you, since you're already experienced? You've done a lot of cases on the undergrade, in the undergrade direction. How difficult was it to adapting to these new techniques, the retrograde, the ADR that came down the line? Was it something natural? Did it take a lot of effort?
It was, in a way, it was a natural development, because we developed one, or we got in contact with one technical step after the other. Now all these techniques are on the market, and the technology is very, very developed, very well developed. And so the colleagues that go into that field nowadays, they jump in on a very high level, and this might be a part of the problem, because they are not, let's say, humble enough to go slow, to learn one step after the other, no shortcuts. And so this is a little bit difficult sometimes, also when you are proctoring, what I do a lot at the moment or during the last years, to teach how to approach and to approach these CTO interventions in a safe manner and effective manner.
So you have trained many people and you continue to train them, as you mentioned. How can you tell if someone who wants to learn CTO PCI is going to be a good operator? Is there something we can tell when you meet with them or when you see them operate? Is it something you don't find out until later? Is it the character, the skills? How can you tell if this person is going to be a good operator or not?
Yes, I think it's quite easy to decide on that when you work together with a person, with a colleague at the table. But in our center we had many colleagues. We had, I don't know, 12 colleagues who did PCR interventions, but only 2 or 3 of them had an interest to develop their skills in CTO PCI, because they said, I'm not mad, I don't want to have so much radiation exposure, I don't want to stand there for 6 hours, and it is not good for my health, and I'm not interested. And so I think it's a combination of personal characteristics. You have to have a certain persistence. You have to keep calm even when you have difficult situations or complications. When your material falls out, you have to be humble and start again. What works once works twice, and then you build it up again. And so it's a lot of psychology in it as well. And what you also see when you work together, during your proctor activities, is the doctor cautious and more on the safe side, or more like a cowboy, and do you have to slow him down a little bit? And so, but usually when you are called as a proctor, this is already a selection of doctors who want to develop their skills, who have these characteristics, who have a lot of experience yet, did hundreds or sometimes thousands of PCRs. They know how wires work, how catheters work, and it's quite easy to tell them the tips and tricks that they need to get to know to the technology and the techniques of these CTO specialties. It's quite easy to transform that.
And Achim, how do you deal when complications happen? Both when you're practicing, also when you're proctoring. How do you deal with the stress, the approaches? Is there specific techniques you developed over the time, or?
I remember your last presentation on complications and your algorithms, and I learned a lot from that, and I learned a lot from complications I saw. And okay, number one is you always have to think that a complication can come anytime. Often they come without any expectance from your side. You have a normal sized balloon in the mid LAD, and suddenly you have a rupture because something breaks open, and then you have to know what to do. You have to have the material on board, covered stents and coils and embolization particles and fat, and how to deal with the fat you harvest, as you showed it very nicely in your textbook. And yes, you have to keep calm. You should look for an experienced colleague. If you work alone, come in, and now what can we do? First is always to block the proximal vessel, to stop bleeding, and then to think. And it's a kind of an algorithm in your head. And I think many of us have seen many of these complication sessions and have their engrams, we call it in Germany, in the brain, how to react. But still, also during my last years, I do a lot of proctoring since, let's say, 6 years, since I retired from a hospital job. And every now and then you see a new kind of a complication that you never have expected. So it never ends. You always will. It will always be necessary to learn again from complications and to be better the next time if you're confronted with any of those.
Yeah, absolutely. That's true also not only for complications, but also for the other cases as well. Are there any cases, good or bad ones, that have stood in your mind, that have taught you a lot over the many years you have been doing this?
I must say, you learn from every case you do, and you learn from every case you see. And this never stops. I'm now 73 years old since a few days, and I still
Congratulations.
learn, and I still love to do complex cases. When they send me a movie, I sit there and I really look forward to stand on the table and to deal with the problems that will come up. And so it's always this learning process has different aspects. Sometimes you learn from if you have a concept, if you have a strategy, and the strategy works. So it's also a kind of learning because it stabilizes your strategy. You have many situations where the technical modules you have learned, modules of CTO PCI, like wire escalation, parallel wires from entry rate, or reverse card, or tip-in, or externalization from entry rate, where you want to implement them, but it does not work because your microcatheter gets stuck. Your microcatheter from integrate gets stuck, and the one from retrogate gets stuck. What can you do then? And so it's always a part of concept and strategy, and some astonishing things that might happen. And the other day, excuse me, I jump a little bit. The other day, I had an interview with Masahisa Yamane. And he said, okay, yeah, that's right. And we have to be creative and intuitive. I said, okay, and how do you teach to be creative and intuitive? I asked him. And then he said, yes, they have to stand beside me and see how I struggle. So even if you have all the strategies in your brain, you have to improvise every now and then. And because of that, it stays interesting. The whole field stays interesting.
And that brings us actually to the question of how you keep your motivation. I mean, you're obviously super motivated still. You seem to be super active and in good shape. So, how do you keep motivated to be doing these cases, proctoring, teaching other people?
It's great fun. You work together with experienced doctors. They have a high motivation. It's always interesting to see how they work in other cath labs. You should do that during your regular job, going everywhere and see what they are doing. You can always learn a little bit, checklists or what they have. And for me, it's not only the teaching process. I always proctor as a second operator. I always stand aside and let them go, and almost never touch anything. Sometimes I go there and said, no, we should turn the microcatheter like this a little bit faster, and so and then I step aside again. Sometimes when it's very, very complex and everything is integrated and retrograde and calcified and so on, then I jump in and stand there for 2 hours as well. But usually I only stand aside besides it, and it's still from the topic, from the technical aspects, it's still also interesting for me. It's not only the teaching; it's also my case, and it's also that the patient who comes there, he has a great expectancy. You know, it's sometimes 1 or 2 failures, and then they say, "Oh, there's an experienced colleague coming." So the patient, it's really also for the patient. And what I always want to avoid is to have a failure. Okay, I know you always have to balance risk and clinical need, and we have to learn when to stop. But this is often not so easy. You need some help from outside sometimes. But it's not only the teaching. It's still the interest in the whole field. It's also for the patient. It's the interaction with the colleagues. So for me, it's always a great adventure to go into other cath labs, to other colleagues, and work together with them.
And Achim, how do you keep fit? Do you exercise? Do you do any meditation? How do you keep in good shape to do all this?
Yeah, okay. My hands are still quite calm, and I can still stand for 6 hours. It's interesting sometimes because I don't lose so much adrenaline compared to the doctors who stand beside me, because they are in their whole surrounding and they have to be successful, and they don't know me sometimes, and so they lose. These techniques are all new for them, so they lose a lot of adrenaline. And sometimes after 3 hours, the doctor has to go out and sit for a while and drink something, and then I'll go on. I go on in between and wait until he comes. So I don't mind. It's for me, it's still okay. I make some sports more than ever, I must say, some bicycling and tennis and a bit of fitness studio, and maybe not enough, but still some sports yeah.
And then how do you relax after all these cases? Is there some the cases relax you? Or you have some techniques to keep you calm. Always live very calm and composed during and after.
Okay, it usually nowadays it's easy. My life is easy, because I proctor 1 or 2 days per week, and then I have enough time to recover. But during some phases or years in the hospital, it was more complex because we had about 500 CTOs every year in Bad Krozingen. And because we were a referral center for CTOs. And then all these valve interventions came up, these structural valve interventions like TAVI and MitraClip. And the experienced doctors did all these interventions. So I did CTO and then 2 TAVIs and then a CTO again. But sometimes I had one CTO and they did 3 TAVIs. So it is at the same time. So it was very intense. I think now it's specializing a bit more and it's a bit more organized. But when these techniques were new and came up, it concentrated on the more experienced ones, and later on the others learned it as well. But nowadays it's easy.
And then, sure. And then, do you have any favorite book or any favorite movie?
Oops. You think a cardiology book or
No, any book, any book.
Oh, this is
any book.
This is an interesting question because we have a nice group, eight colleagues, 8 friends, and we meet every 6 weeks, and we read a book. So this club exists since 2000, since the year 2000. And now we read, I think, nearly 300 books together. And the one who suggests a book for the next meeting, everybody reads it, but the one who suggests a book, he has to present it. And so it's really intense and you have to read it twice. And then you talk about the book. First we eat and drink, and then at 9:30, somebody says, now we should talk about the book. So we really read a lot of books. I must say, I don't know. I have a favorite book from all these different ones that we read, but it's the title is Deutschstunde from Siegfried Lenz. It's a German book, but we had a broad spectrum of other books that we read together. And film.
Well, that's a great way to do it.
Yeah, it's good. It usually the ladies do that, and 2 of my friends, their wives had such a club, and then they said, "Oh, we should meet as boys as well. But if we don't have a program, we only drink beer and tell the last jokes, and so we should have a program." And it really works nicely. It's always interesting to hear the opinions of the others.
Love it. And then, how about film? You think about your favorite movies?
Again, a broad spectrum. I don't go into the cinema too often. Yeah, the last one was Anatomy of a Fall. This was a fantastic movie. It's from a French regisseur. Trier, Madame Trier, has made it with a fantastic German actor, Sandra Hülster. She just won a few prizes. It's a very actual film. It's Anatomy of a Fall. Very interesting movie. This was the one who meant most for me of the movies of the last time. Oppenheimer was a good movie, and others as well. It's a broad spectrum. I like culture. I like cultural things. My wife and me, we when we're in a city like Paris or Vienna or also Zurich or Berlin or so, we always go into the opera. So this is something that is good for the voices, for the music. They are also good actors nowadays, and it's always an experience that really may overwhelm you with all these different aspects. So we love to go to the opera.
Which is your favorite opera? Actually, I'm also a big fan of opera as well.
Yeah.
Do you have any favorite opera, or you're open to everything?
Difficult to say. A few operas we saw many times. Richard Wagner. Okay, this started a little bit later. My first opera, I heard my first opera in New York when I was 38 years old. This was in the Metropolitan Opera, and we got one of the return tickets, and then we jumped in. This was Othello from Verdi. Othello. Fantastic. It was fantastic. We had the last row, very far away, but these female voices are something incredible for me. And this was Tiri te Canava at this time. It was a real experience. And this was our first opera. And then we got a contact with Bayreuth. And so we went to some of these Wagner festivals, Richard Wagner. This is always 4.5 hours, or altogether 5.5 hours with 2 breaks. And but the more you know about it, the more it wakes the interest more and more. And it's a great music. And so maybe Tristan and Isolde is one of my favorite operas. Elektra from Richard Strauss, Salome from Richard Strauss. This is all more or less the same musical period of Richard Wagner as well. So interesting music with not too harmonic. It has a great tension in the music and in the topics for the opera or the content.
And some people say it takes a lot of patience to listen to an opera. Do you think that this helped your medical procedures as well?
I don't know. I don't know. Yeah, but patience plays a role. As we said before, to try to stay calm. And to regain control on what happens when we have problems in the cath lab, we have to fix them ourselves. Yeah, as I said, it's something. Always something can happen that you didn't expect. The other day, I can tell you shortly. The other day we had a rupture of a epicardial collateral. It was a successful intervention of the right coronary artery. It was a collateral from a diagonal branch to the PLA of the right. The right collateral, the RCA was recanalized and fixed, and with the retraction of the microcatheter, there was a bleeding. And the bleeding could be stopped from antegrade, from retrograde, and there was a small additional bleeding. We stopped it with first it was coils, and then it was microparticles. Every bleeding stopped. And then still blood was aspirated, 50 milliliters, 100 milliliters. And then the surgeons were in the hospital, and they said, we have to open it. Maybe you destroyed something or so on. So they opened it, but there was nothing. There was no bleeding from the heart. It was a diffuse bleeding from the pericardium. And this was a patient who ran into a DIC just from a pericardial occlusion at a let's say a blood loss of 400, 500 milliliters. I looked through hundreds of case reports on DICs, and I didn't find one example like this. So that a local bleeding triggers a DIC, you stop all the reasons, and then usually it stops, and patient goes on the ward, and next morning everything is good. But the bleeding went on and on and on. The patient survived. This was a fantastic hospital. They really could manage it with tons of factors that had to be given, but she survived. But I never saw anything like this. I never saw any literature expound for that. So it always might happen that something comes up that you were not confronted with before, and so then you need the whole hospital system. You need the intensive care unit. And with all with the best treatment, then the patient has a chance. And so we are really teamwork, especially in these special cases.
Yeah, no, I completely agree with you. We're very privileged to have a very strong, heart failure, ICU teams, heart surgery, and that makes a huge difference. In cases like this where things go south, having this team behind you clearly makes a big
Absolutely.
part. So, Achim, you said you retired, but in reality, you're still working. So, how was your decision there? How you decide to retire or to continue to work now as you're still doing some proctoring? How did that thinking go in your mind?
Now, for me, it was fantastic because I had the agreement with my wife that I should stop my job because I came home late and I was always excited. I always loved to go into the hospital and I loved my job. It was ideal for me. And the hospital was fantastic. So I said, okay, I retire with 66 years, at this age. But I have to go on proctoring. And then many requests came. I could have made a full-time job out of it. So, but it got a little bit less and less, and because others proctor as well. And now I'm quite busy in Switzerland and sometimes in Germany, and it's like once or twice a week. And for me, this is ideal. This is absolutely ideal. And we usually do 2 or 3 patients per day, and sometimes it's fast. And what I always say, this is a part what I also wants to transport, because in this interview, because I think it's very important that we try to teach a systematic approach to CTO PCI, and a very important message from my side is always start from integrate and all the way through the field XT. Because if you don't do it, you miss so many chances. So my last 5 proctored cases, 4 worked with the Field XT. It just goes and it just enters the true distal lumen and you get it for free. And you don't spoil anything. So 70% for integrate, half of it with Field XT, and only the other half is wire escalation, or how you want to call it, or parallel wires, or all that stuff. But half of it is only one wire. It's not wire escalation. And so this is one step. And then the other steps come, one after the other. But from my experience also, the more experienced the colleagues are, the more systematic their approach is. And this helps very much.
So do you still, as you say, you still upgrade your algorithms? So you always start with the undergrade, always start with the filter XT. Like, for example, what do you do if the proximal cap is not very clear about where the proximal cap is?
Exactly. Then I use a Field XT. and if it enters,
so you're very systematic.
If it enters, there are so many cases where we are deeply convinced it will never work. It's a blunt occlusion at the takeoff of a side branch. There's no visible macroage, nothing. But it goes, and the ambiguous cap. Okay, proximal right coronary artery, a conical branch, a right atrial branch. Nobody knows where it goes. But give it a chance. If it goes, it goes. It finds a microchannel or soft tissue, and it doesn't spoil anything. And then you can go on, and you say, okay, then the next step comes, like, I don't know, Gaia, 2nd or 3rd or something like this. And then you have to develop other ideas, like do an IVUS or so. But always start with the Field XT. Don't think too much.
And how did you divide this approach? Is it that through your experience? Do you see other people? Like, how did you get to this conclusion to always use the Filter XT as your first wire?
I started with that in 2007, and no other approach convinced me that there's a greater chance with less material, with less risk, than going with the Field XT. For me, it's still the greatest invention of all this material, because it follows the less resistance, and it enters a channel that you don't see. It enters soft tissue. Sometimes you have an extremely complex CTO lesion, JCTO score 5, 4, something like this. Calcium, full of calcium. It goes around the calcium nodules, and it makes a crazy curve here, but then it's in the distal branch, and you get it for free. the wire passage, but then the work starts and you need another 3 hours until the stents are in. That's clear. But if you don't use this, you don't get this experience. So I always take it. Not always. Never say always. That's clear. But almost always.
So, Achim, you've done so many things. What are you most proud of the things that you've done over so many years in clinical practice, proctoring, etc.?
You know, we have such a lucky field in medicine. We have success rates that are above 90%. We have happy patients. We do interventions that are not painful. They are so elegant. It's a tremendous success story of all these catheter interventions, also for structural heart. So it's fantastic. So the progress, the technical developments, everything is going like this. And so we are used to have high success rates. And it's always, when you have success, it's fine, but you're used to have success. And what is, for me, is more interesting, how to deal with failures. Because when I have a failure, I really want to avoid it. But when there is a failure, also when I proctor, it's always my failure. I take it personally, and I don't feel good for the next 3 hours. Then it's fine again. But it lasts longer than a good feeling lasts. Yeah, it lasts longer. Yeah, you always think, what could you have done different? And you're sorry for the patient. You spent so many hours and material and had a complication eventually, and for nothing. And this is more my problem: how to deal with failures than how to deal with success. I don't know but success is. It's not so important. Let's say it this way.
And Achim, what excites you for the future? What do you think is the next frontier in what we do, and the next things that will make things even better and safer?
Yeah, it's not so easy to imagine because, the real experts have success rates that are higher than 90%. Even with proctoring, you can reach success rates that are higher than 90%. But so there's not so much space. So we have an asymptotic approach to an ideal. You will never have 100% because there are some things you can't influence. Diffuse disease periphery, you can say it was successful, but it doesn't look like success. So it will never be 100%. So there's not so much space for let's say, developing towards success, towards higher success rate. We can make things easier with technical developments. We can spare X-ray exposure. We can broaden the technique more and more because things could be easier in the future than they seem to be now. But I'm not so sure. I think with all these robotic systems, I don't want to. We make only 4 movements. We work in tubes. We make only this and this and this and this, and a robot can do that. But it's so much in between, and I don't want to be treated by a robot when the doctor is sitting. Maybe in a prostate surgery they do it with this. It's like Star Wars, and the robot arms are working. But I think in simple PCIs it could work, but there is so much tactile feedback. There's so much, being intuitive as well. You have an idea on the course of vessels. You have seen so many different courses of right coronary arteries. So you develop an idea. You feel that there's resistance. This could be the right way. To tell a robot to do the same, I think, or to give the same feedback will be very difficult. I don't know. Maybe other fields will be more interesting. What Thomas Lüscher said the other day, Thomas Lüscher, he was the boss of the University Hospital, and in Zurich, he's still active. He is the president-elect of the European Society. He had a very nice talk in Lucerne the last year. And he said there are 2 interesting developments. First, radiology will totally taken over by artificial intelligence, and there will be no coronary artery disease anymore in 20 years. This is interesting. So we have to think about what our children, or what your children and their children should learn in the future. The idea was that the PCSK9 gene can be changed by CRISPR-Cas, and if you do that on a population scale, you can vaccinate people against vascular disease. So I think this is an interesting idea, and they have their first studies on that already now published in a few patients.
Yeah, absolutely. Yeah.
Could be something. We will see.
So I guess it's a good thing we're doing our career now versus 20 years. You never know if CTOs will exist by then.
For us, it's fantastic, really. And also for me, it was fantastic. All these developments over time, they were incredible. I think it's much better to be in a phase where techniques develop than to jump in on a high level. I think it's a privilege to have the chance to be a part of these developments.
Wonderful. So Achim, you've done again so much experience, so many years teaching, doing it. If you had to give some advice to the beginners, people who are early in their fellowship or early learning, what would be your top advice for them on how to learn and be the best they can be?
Okay, my first advice would be, if you start with PCI, try to provide the whole spectrum that is in the method. Don't say, no, this is too complex for me, I send this patient to the surgeon, when the situation is still doable with a catheter intervention. So try to learn as much as possible, so to really use all the possibilities that are in the method. And that includes also these CTO techniques. When you learn these techniques, you're also a better non-CTO interventionist. That's clear. So this is a very important message. Try to stay on the safe side, be more defensive, don't be too aggressive. Learn the technical things step by step. Don't use shortcuts. Take your time. You can do many things by yourself. If you're an experienced PCI operator, then you can start from antegrade. This is not a problem. But at the transition to retrograde interventions, you have to find an experienced colleague or a proctor by your side. This is not good to do that learning by doing, especially the first step always is the passage through collaterals. And as I said before, this is lifelong learning to deal with these interesting structures. So step by step is very, very important.
Wonderful. And what is your advice to help them keep motivation? Because they will have failures, they will have difficulties, there will be long days, not successful always. How do they keep the motivation like you have right now?
Okay, the motivation is, not to start with the most difficult cases. From the beginning, you have to do very good case selection, and the advice of the experienced colleagues are very, very important. When you see an angiogram and when you plan a PCI, you have to look very properly on the angiogram, not just a short view. Let's start. So please look very, very intense. Look frame by frame, just when you deal with CTOs, see where's the first filling of the occluded vessel. This is the functionally most important collateral. Where does this collateral go to or come from? Is it an interventional one? So really take your time, make your plan A, B, C. And if it's complex, don't do it alone. Do it together with an experienced colleague. So step-by-step learning, step-by-step increasing the difficulty of the interventions. But the problem is, to predict how difficult the lesion is. And sometimes you say, oh, that's an easy case, 1 centimeter CTO, but it's extremely difficult. And the other way around, it looks very difficult and it's fast. So even for an experienced colleague, it's still difficult to predict how complex the intervention will be. So it's not so easy.
So practice. I guess that's the way to go.
That's right. That's right. Yeah.
Well, Achim, thank you so much. Really appreciate you taking the time. A lot of piece of wisdom. I think you've had phenomenal impact on the patients and many operators, on both sides of the Atlantic, I would say. So thank you so much again for everything that you have done. And I'm sure we'll see you again in one of the meetings down the line.
Thank you very much, Manos. It was a great pleasure to have this talk with you. I really admire you. You don't realize that, but there are so many good feelings that are coming over the Atlantic from my side, because you have a fantastic textbook. You do so many research work and so many publications. You're so important for the field, and you're an extremely nice guy. This is also very important to say. And stay as you are.
Well,
Stay
very,
like
very
you are.
kind of you.
Stay like you are. Thanks a lot.
Well, many
Thanks
thanks.
a lot.
Many thanks again, Achim.
Bye-bye. All the best to you.
Thank you for listening to the Sensei podcast.